Okay, hello and welcome everyone. So in this video, I'll start off by talking about the demand for health, the production of health, some of the factors corresponding to the determinants of health, and ultimately the demand for health care. So a lot of what we do, thinking about the demand for health, is following the treatment of the demand for health coming from Michael Grossman's paper in 1972. The idea is we're realizing that, well, people have some demand for health, and we can model this using economics. Right? There's a lot of factors that contribute overall to health, some of which are things that people are choosing, some of things are things that people are purchasing, and so on and so forth. But what we want to do is amongst all these things that contribute to the demand for health and that contribute to good health overall, we want to think of what is going to be the marginal contribution specifically of healthcare. Because people wouldn't necessarily want healthcare, what people want is health. So the demand for health care is driven by people's demand for good health, but maybe there's other ways to achieve good health apart from certain types of health care, right? They're not certainly entirely mutually exclusive. Obviously, that's ridiculous, but there's ways that maybe we could lessen the overall demand for health care by increasing the other ways that people are able to maximize health. All right, so in order to do so, we want to think about, well, what's the marginal contribution of medical care and what's the contribution of the other things? Furthermore, we can think of the production of health. We can think of like, well, people want health, people want good health. They have a demand for good health. There's different things that can help achieve this. Think about the production of good health. So we can think of health production as being driven by lots of inputs. Following Grossman, we think of this as being the production of health being achieved by, well, consuming medical services, spending time devoted to achieving one's health, and then human capital more generally. Human capital we can think of as like enhancing some of the value of some of these other activities. Right, so the basic idea is we think of, well, we can think of how health is produced at the individual level and then at the societal level. In order to do this, well, we want to have some good measure of health status. So we have a couple different measures, two of which are morbidity and the quality of life. We want to come up with ways to be able to facilitate comparisons across individuals and across societies. Morbidity, here we're thinking about the incidence of adverse conditions. So here we might focus on something like the number of work days lost or restricted activity days as some objective measure that we can then compare. We want to think about like what has been the impact, how many people have been affected by whatever is this adverse condition, this illness or disease. We can also measure health status through quality of life, maybe through the QALY, right? Quality adjusted life year, to make some comparisons across alternative programs that could facilitate health status, right? In terms of like thinking about the economic evaluation and the cost effectiveness analysis mentioned earlier. Okay, well, if we're interested in trying to make comparisons about quality of life, that's good. Here we have this measure that's gonna involve something about the quality, the satisfaction, the preference people have for life, crossed with survival duration, meaning the number of years. We're not looking at just pure life expectancy with QALYs. We're looking at like the value or the enjoyability in some sense weighted by the quality of those years. So that's what quality of life is doing. And of course, well, there's different ways to measure these sorts of things, and this can add some noise to the analysis. Next, we want to think about the determinants of health status more broadly, right? People have a demand for health status. And one of the things that contribute to health status is then also going to be medical care, but there's other things. So for instance, there's a relationship between income and education, human capital. And on average, people who have higher levels of income and higher levels of education are also going to be healthier. There's environmental and lifestyle factors. Some of these is just the world around the people. In some cases, the income and education determine what environment you're going to live in, and vice versa maybe. There's also lifestyle factors in terms of what types of habits people have in terms of diet and exercise, and then alcohol and tobacco or whatever is the case. And those are also determinants of health status. Lastly, there's genetic factors distributed in the population that are also determinants of health status. Some of these are influenced by some of the things mentioned above. So there's interaction effects, and this makes the analysis a little bit more complicated in that, yeah, income and education affects health status, and environment and lifestyle affects health status, and genetic factors affect health status, but these things are all interdependent with each other on one level or another, also contributing to an additional marginal contribution of each of these to health status. Lastly, we want to think about the demand for healthcare. So people are ultimately interested in increasing their health status. At the same time, we recognize, well, there's those factors just mentioned that affect health, but there's also health care and medical care that supports and seeks after improving people's health status. Here, following some of these other economists, we can think of medical care as an investment. In some sense, it's improving human capital by allowing people to be more productive than would happen in the absence of health care. Right, with health care, people are able to get back to health and then get back to being productive. In the absence of health care, we're assuming that the disease state persists much longer and maybe is terminal. So the demand for health is ultimately based on the wanting to feel better, but also on the demand for wanting to be more productive. The more value there is, the greater their returns is to being highly productive, the greater is the demand people might have for healthcare or for health and then healthcare. So one of the things we might wonder is in terms of like patient factors, well, thinking about, are there substitutes for medical care and what might those look like? In terms of health status, well, a person's health status definitely matters for the demand for health care, with those who are either in poor health but wanting to be back to better health, or those who want to maintain good health having the greatest demand for health care. Demographic factors are certainly relevant. The larger is the population, increases the number of people seeking after health care. Certainly aging is important, so think about the life cycle, and aging patients are probably going to demand more health care on average. And then there's physician factors. Interestingly, there's a principal-agent problem here, which echoes some of the issues from moral hazard mentioned under asymmetric information. In some sense, the physician is going to be both a provider of medical care, but then also a demander, because they can order tests and they can recommend other providers for patients to see. And so in some sense, there's scope for the patients to be acting for the physicians to be acting opportunistically, whether that happens consciously or unconsciously. Remember, after all, our list of special characteristics about healthcare that Arrow identified is one of them is the trust that patients have for physicians, basically not to behave opportunistically, not to order tests that benefit only the physician and not the patient. But indeed, this is something where the physician is both appearing on the supply side of medical provision, but also on the demand side.